Okay. Okay, I'm going to just jump right in and get started. So I'd like to welcome everybody to the Optometric Retinal update. Thank you so very much for being here. Give yourself a round of applause. You registered early. You made my life easier. I mean, it was so great to work with all of you. Thank you so much. I'd like to introduce our sponsors. We have the Retinal Foundation as well as Astellas. Astellas is back there. We have Anne, Kevin, and Jessica. Thank you so much for your support. Give them a round of applause. I'd like to introduce our speakers tonight. I'd like to thank them for putting the time and effort to put together very quality and educational presentations. We have Dr. Sean Platt, Dr. David Shieh, Dr. Alexander Miller, and Dr. Arnold Nothnagel. Thank you so very much. I'd like to thank Geographic Vineyard. It has been such a pleasure to work with them. Any call or any concern I had, they responded to me right away. They have been wonderful to work with. And I'd also like to thank our wait staff. They've been taking such great care of us. Thank you so very much. I'd like to thank our staff, Kim Lunardi and Pam Rowe. They've been such a great help at registration and getting the room set up for us, so thank you so very much. And lastly, I'd like to thank Q Audiovisual. You guys have been great. You provided the speakers, the microphone system, recording. You have just been completely on top of it and answered all of my questions and concerns, so thank you. This event will be recorded and there will be no break, so please take them as necessary. So I'll be sending a recording out once I have that link available, so anything you may have missed, no problem, we got you. You can watch it later. You will receive 4 continuing education hours for attending this event, and please take the survey following this event. It helps us to provide the best events possible for you in the future. Any questions you might have following each presentation, just go ahead and raise your hand, and I'm going to be around with a microphone so everybody can hear your question, including the speaker, as well as the people who couldn't make it tonight, so that it'd be caught on the recording. Updates. So as you may have heard, our new Canton office is open. We opened it at the end of October, and it's a very beautiful facility, much bigger than where we were. We're actually a half mile east on Monson Street than where we were before. This is the inside, so you see the inside lobby area and the check-in desk right here. This is what our employees think of it. They are thrilled to be in the new space. They are loving it. We could actually have 2 doctors seeing patients in this space now as well. Our Dover office is under construction. We're actually moving from a couple floors up to the first floor, so that's currently being renovated, and we expect that to open in the spring. So we're in the same space, but we're just moving a couple floors down into a new space. We have a new Sandusky office opening in the spring of 2026. We actually do have a satellite office out there right now, but we are moving into our own space. It's been a pleasure working at the satellite office, but we decided that we would like an office of our own. And anytime you want to follow any one of our doctors at any one of our 13 locations for continuing education credit hours, just let me know. Just shoot me a text or shoot me an email. I'd be happy to set you up with those. And our first speaker of the night is actually going to be Dr. Arnold Nothnagel. So I'm going to get him set up, and he'll be presenting soon.
Can everybody hear me okay? Okay, good. Okay. fighting a little bit of a cold, so if I have a little congestion, I apologize for that ahead of time. There is an advantage of getting here early. I get to go first after all, so I'm very happy about that. We're going to see if we can go back here. Yeah, it doesn't go back, okay. So just a couple of boilerplate slides to begin with. Macular degeneration, these are nuts. These are not, oh, I see how it's going, okay. So let's just find out what the sequence is on this thing. Okay, so macular degeneration is the leading cause of irreversible blindness. It's a boilerplate slide, but still important. 288 million individuals will be affected by the year 2040. And, over the last 20 years since we had these wonderful treatments, our anti-VEGF treatments, which obviously everybody in this audience knows the efficacy of these. I've had a bias myself over the many years saying, well, it's wet macular degeneration all day long. But it turns out that actually GA and corneal devascularization, as far as advanced AMD in that category, they're really equal. There's 5 to 6 million cases of GA and 5 to 6 million cases of corneal devascularization. So the pathology is just as advanced with geographic atrophy in terms of sheer numbers. And again, 160,000 new cases per year in the United States. And if you look at the little graph there, we all know this anecdotally through, we're like internal medicine now. In the old days when we did the laser and it didn't work, people would just go away and go blind, unfortunately. But now with anti-VEGF, we follow these patients for such a long time. And you'll see these patients come in and you're treating them with the anti-VEGF, only see them go blind when they're in their 80s, traditionally from the geographic atrophy. But since everybody's living much longer, there's no doubt in your guys' clinics you're seeing this as well, just a plethora of GA cases as people get older. So natural history, the term geographic atrophy was introduced by, I like to refer to him since I'm a little older now, as the godfather of retina, Don Gass. I mean, as I said before, the observations this guy made without OCT or anything, and many of them have stood the test of time, just an amazing individual. So he's the one that coined the phrase. And again, one of the definitions, a sharply demarcated zone of partial or complete depigmentation of RPE, typically with exposure of the underlying large corneal vessels in the absence of CNVM in the same eye. So if you look at the literature, there's been a lot written over the last 25 years, way before we've ever had any treatment for GA. But I think there's a couple, probably a good idea to hold on to a couple figures. So, and we'll go through these, but there's just a million papers out there with a million different figures. But one that you can look at is on average, if you're looking at just area of progression, in general, 1.78 millimeters squared per year. And in one study, this one from one of the slide stacks, in one study, they predict that when GA is first discovered and it's non-central, it'll move to the fovea in general in about 2.5 years. So quickly on the natural history, again, there's many papers written on natural history. I kind of hooked onto the ARID study because it's just a nice, very well done study. In the ARID study, 4,203 participants, age 50 to 85, and they looked at intermediate AMD, there's large drusen, but they had an advantage because many of these patients already had late AMD, that is GA or corneal devascularization, so they had a whole group of eyes to study. And going back to Ferris's classification, there are no apparent changes, no drusen or RP abnormalities, normal aging changes, which they refer to as drupelets, early macular degeneration, medium drusen, 63 to 124 microns with no pigment abnormalities, and then intermediate, larger drusen with or without pigment abnormalities. So you always look at that 125 micron drusen. What is that? Because you look at these patients, well, if you're going to follow that, what does that really mean? A large druse would be equivalent to the diameter of a vein as it enters the optic nerve. So if you're looking at that, you say, well, is this patient earlier than intermediate? All you have to do is just compare the size of the druse or drusen to the size of the vein in that given individual as it enters the optic nerve, and you're going to have a pretty good indication of what category they're in. And then, of course, late AMD, just is neovascular corneal devascularization and or any GA. So in the natural history study, they looked at two cohorts. They looked at the prevalence cohort, which they define as eyes that had GA at baseline, okay, and the incident cohort, eyes that developed GA during follow-up. So what they found in the prevalence cohort, those that had GA as they entered the study, 2/3 of them were non-central, and unfortunately a third were central already at presentation. So in the incident cohort, basically 20% developed GA over 5 years. So when you see that patient with a GA, or intermediate or advanced intermediates we're going to talk about, they're going to go on to a GA on average in about 20%. So interestingly, in the incident cohort, as they follow these patients and follow those 20% that developed, it was exactly the same. 2/3 of the patients presented with non-central GA. A third of them, unfortunately, presented right away with central GA as their first indicator. So a little different statistic. We were looking at one a minute ago that said if you have non-central GA, it progresses to the fovea within 4 years. This is one I would more hook onto because it's such a well-done study. In this study, 60% of those patients that had non-central GA progressed to the fovea within 4 years. Okay, so you'll see these patients. 4 years sounds like a long time, but if they're relatively young, I mean, this is just an average, of course, as we've all seen in our clinics. And that's one of the big problems right now is knowing when you see that patient, are they going to be a quick progressor or a slow progressor? It's a huge unmet need that we'll talk about at the very end. But on average, again, almost 2/3 are going to be in the fovea within 4 years by natural history. And again, just a statistic to hook onto, in the prevalence group, those with pre-existing 0.29 millimeters per year. So if you're looking, you can obviously look at it as a linear measurement as they did, or the millimeters squared. But as far as linear measurement goes, 0.29, and in the incident group, 0.28 millimeters per year. So again, whether the patient's pre-existing or they develop GA, once they have it, they're going to progress at a pretty constant rate, irrespective of how long they've had the disorder. Okay. So again, in summary, looking at eyes that have high risk for progression to late GA, increasing age, we know that. In fact, when patients hit 80 years of age or older, geographic atrophy, as far as visual loss, is more common than choroidal neovascularization. So as patients hit 80, they have to be watched carefully. Lower education level, as we'll talk about at the end. Why would lower educational level make a difference? I just think we'll talk about diet. Lower educational level, unfortunately, corresponds usually to a lower socioeconomic level and poorer diet. So I think that's to me, that's a dietary thing. Positive smoking status, and then a term, advanced intermediate AMD. So risk of faster progression, again, from the ARID 16, GA presence in the fellow eye, intermediate baseline lesion. Very small lesions tend to progress slowly, and large lesions burn out. They don't progress as quickly. Extrafoveal lesions progress more quickly, so not that it's an advantage, but if you do have a subfoveal lesion, that lesion in general is going to progress more slowly. Multifocal lesions progress more quickly, and positive smoking status. So diagnostic modalities. A lot of the older papers were really based on just color fundus photography, which is inadequate. Fundus autofluorescence, fluorescein angiography for historical purposes. I don't know if anybody would use fluorescein to diagnose GA in this day and age with multimodal imaging. And then a combination of B-scan OCT and the near-infrared that accompanies the Heidelberg views. So I don't use one of these specifically. I use FAF and B-scan and NIR and the exam along with the color photo. Just kind of a synthesis of all these different things, let you know where they really stand on their GA. There was a series of meetings over the last decade called the Consensus on Atrophy meetings that tried to move from looking at color photos and somewhat from fundus autofluorescence to use B-scan OCT as an arbiter of what's going on with GA. And they coined the term, as some other papers did. We talked about intermediate AMD, meaning 125 micron drusen or greater, with or without RP abnormalities. But in advanced intermediate AMD, there's a series of these, 1 through 5 and number 6 that we'll talk about. I think this is really important because virtually everybody in this audience has a OCT now, and I'm sure you're all getting scans on every one of your AMD patients. So as you're sitting in your clinics and you go through this, these are things you can look at very, very quickly and lock onto. It will help guide you. I mean, if the patient doesn't have GA, if you look at any of these lesions, you know this patient's at increased risk and is going to have to be followed up more carefully, okay? So if you look at this, basically over here, you're looking for loss of the RPE, and the ellipsoid zone just kind of disappears there, and then you just have complete disorganization. This patient also has something called subsidence, which we're going to talk about in a minute. Also has some intraretinal hyperreflective foci, which we'll talk about. But basically, it doesn't have to look like this. I mean, you'll see a lot of your OCTs that look a lot cleaner, obviously, than this one does. But they're going to show disruption of the external limiting membrane, the ellipsoid zone, maybe the interdigitation zone, and thinning of the RPE. Early on before they ever get this subsidence phenomenon, which we'll talk about. So if you're scanning through quickly and you start to see some disruption of those outer retinal layers, that is a patient that's at risk and should be followed more closely. Intraretinal hyperreflective foci, these little, you'll see these, there we go, yeah. You'll see these all day long in advanced intermediate. What this represents is RPE cells that have migrated from the RPE to an intraretinal location. And if you follow these, they'll become more numerous. It has a couple over there. And they tend to migrate. In this case, it's kind of juxtaposed between the outer plexiform and the internuclear layer. And they'll migrate all the way up into the ganglion cell layer. So, but that's another sign. They tend to aggregate over drusenoid PEDs, such as in this case, and soft drusen, which kind of makes sense since that's one of the main factors that you'll see that's going to be at risk to develop GA. So here's a patient from the Dover office. In May of 2019, patient has soft drusen and drusenoid PED. Going forward to 2023, the drusenoid PEDs are starting to collapse, starting to get a little bit of concavity in the layers there, this thing called subsidence. January, just about resolved in terms of the drusenoid PEDs, starting to get this barcode hyperfluorescence type phenomena. And then by February of this year, this patient now has this thing called subsidence, which we'll talk about in a minute, has hypertransmission. There's a complete destruction of the outer retinal layers and marked thinning of the RPE here. So just a progression. This actually, I'd watched this patient for years. They're being treated also for the exudative phase, so they're in often. But this is not a surprise that they went on to this particular picture. So same patient, back in September 23 had hyperautofluorescence on the FAF, now has a temporal GA in that same eye that I just showed the same patient, and they're now on a complement inhibitor as well. So subretinal drusenoid deposits, it's just, these are very easy to recognize. As you just scan through your B scans quickly, they're these spiky type things. I don't think the histology has been well defined on those. They actually call them in class 1, 2, and 3, but basically you're just looking for this, these spikes right along the inner aspect of the RPE, and they're easy to recognize because instead of that nice even line that you'll see with the external limiting membrane ellipsoid zone, you'll start to see them protrude and lift those layers up, and they can actually protrude right through the external limiting membrane and on up there. Also, cuticular drusen, which are sub-RP, look very, very similar. To me, it really doesn't matter. The cuticular drusen and these subretinal drusenoid deposits, they're both risk factors, and so all you have to do is just look for this increasing undulating line. They're very easy to recognize. So again, as you go through your OCTs, you're going to know that patient's at greater risk to develop problems. Okay, and then acquired vitelliform lesions, another risk factor. These are seen both in dry macular degeneration, sometimes a little hard, frankly, to differentiate. Does this patient have exudative disease or is this an acquired vitelliform lesion? Also, you'll see them classically in adult onset foveomacular vitelliform dystrophy, and you'll see them in some traction maculopathies. So here's a patient who presented with the right eye with a classic kind of a acquired vitelliform lesion here, and then was already in collapse resorption there. And then going forward here to September of this year, there's complete collapse and subfoveal RP atrophy, this hypertransmission phenomena, and in the same shape over here. So again, I'm kind of beating this slide to death because for me in the clinic, I use the B-scan as I go through cases quickly. If the patient doesn't have a GA on their FAF, it's a pretty good looking retina. But you have any of these signs here, that's a patient that you probably don't want to bring back in 2 years, or maybe not even a year. Maybe you tell that patient, hey, might not be a bad idea if we looked at you every 6 months, because it's still going to be unpredictable how quickly it's going to progress to overt GA. And then finally, they referenced in the CM report number 5 this thing called nascent GA, but didn't really expand on it. So instead, the CM report number 6 termed this very nebulous, kind of worthless term called IRORA, incomplete RPE and outer retinal atrophy, where they said there's some loss of the outer retina, some loss of RPE, some choroidal hypertransmission, generally less than 250 microns in diameter. So this is actually a slide from this CM report number 6, and they had, the experts could agree that D on the right there was IRORA. It had some RP loss, some hypertransmission, less than 250 microns. I think it's not a very useful term at all, to be honest with you, but I'm just including that because that's what they included in the CAM study. So we talked about this in the past. Along came Geimer and said that rather than look at IRORA, a much more robust sign is looking at nascent GA, which I've kind of alluded to already. So nascent GA refers to subsidence, just a sinking of the outer plexiform and internuclear layer. There's no requirement for the presence of hypertransmission or overt RP atrophy, but they may be present. So this is a patient who obviously has subfoveal GA already, unfortunately. But you can kind of look at the top slide. You're starting to see subsidence there, this sinking of the outer plexiform. The internuclear layer hasn't really dipped too much. This is pretty classic. You get this classic gull-wing type phenomena. This little loosened area is thought to represent edema in the Henle fiber layer, which occupies the outer 2/3 of the outer plexiform layer. So this is in April, and then 4 months later, just a little bit more pronounced subsidence, just this dipping phenomenon, very easy, very quick to recognize, and you're starting to get this hypertransmission in that area. So again, I'll hit it one more time. I think if we look at these quickly, you're going to see these. I mean, it doesn't give you. Unfortunately, there's no published timelines on if you have a soft drusen and drusenoid deposit, which is probably the big number one, when these patients are going to go to GA. Like the other lady I showed you is actually a fairly long time frame, but it didn't necessarily have to be over many years. It could have been over 6 months. So when you see these different changes as you go through your B-scan OCTs, that should ring a bell that you better watch these people more closely. Because, again, as we'll allude to at the end, with our current meds, our complement inhibitors, there's nothing against Astellas or Pellicid one, but they're great meds because it's what we have now. Okay, I mean, 3 years ago we had nothing, and so thank God we have the meds we have now. But the point is, I think you have to start early if you have a willing patient. And so, as Geimer wrote several articles about nascent GA, he said it likely confers a 78-fold increased risk for progression of GA. And just anecdotally, I'll tell you, when I see that on my B-scan OCT, it's not a matter if they're going to get GA in that given area, it's a matter of when. Okay, that eye is going to progress to GA, and usually it's not very long, in large part. So then the CAM report did, however, they wanted to define in a precise way what GA looked like on a B-scan OCT, probably a little bit more useful term, complete retinal pigmented outer retinal atrophy. And they defined it as attenuation or disruption of the outer retinal layers, 250 microns or greater, hypertransmission greater than 250 microns, and again, thinning of the outer layers. And just an example from somebody in the clinic, that in this particular one, this patient was over 1,000 microns, and as the subsidence, but no doubt, I don't have the accompanying FAF on this particular patient, but no doubt, probably if you had a FAF on this patient, it would show overt GA, I'm sure. Okay, so we've talked about a B-scan quite a bit. I personally, I don't know what other people do. I don't depend on the B-scan to help me particularly follow GA. It can be helpful sometimes. Sometimes it's hard to tell, believe it or not, if it is in the fovea or not. So it is good. It's a great tool to look for hypertransmission in the fovea. give you a good idea there. But I use it primarily to look at those different patterns we just talked about to give me an idea of where the patient stands in terms of their risk factors, okay? For me, I think for those of us that have FAF in our offices, it's great because it's a quick and dirty way to look at it. Sometimes not as accurate as I think it ought to be, but it's a good way to very quickly look and see, is this patient having progressive GA or not? And we had talked about this a few years ago. It turns out there are pathologic FAF patterns. It's very hard, or very easy, I should say, in your busy clinics. Just look at the dark spot and that's it. But there really is some merit in looking at the autofluorescent patterns. Okay, and Holtz, way back before anybody even thought about there being a treatment available, looked at these different patterns of non-focal, banded, patchy, and diffuse, he called them. And these are right from his early paper. None means there's no perilesional hyperfluorescence. You have the focal, just the spots around there. Banded means you have a complete line of hyperautofluorescence around that. And patchy he defined as greater than the banded, but it had to still be contiguous with the area of GA that you're looking at. And then he went on and called diffuse, which I think is a little tougher. You got reticular, branching, fine granular peripheral spots. And to me, these look very much the same. The bottom line is reticular, branching, granular, fine spots. The point is you're going to have hyperautofluorescence by definition that is not contiguous in any manner with the area of GA. It's more remote. So in the clinic, you can say, if this patient has a lot of hyperautofluorescence, I don't care which of these patterns it is, that eye's at increased risk to go on to progressive GA probably on a quicker time frame. And then he finally defined this one special one they called diffuse trickling. The only way, these patients are usually in pretty bad shape by the time you see them. He did make the special point that on the FAF, they tend to have more of a gray appearance rather than the pitch dark appearance that we're used to looking at. So I don't know what the histology that is, but they have a grayer appearance. So that particular eye may be at much greater risk. So this is way back in 2007 they wrote this paper, and then most recently, here are the progression rates. He went, and you can see there really was some merit, if you could believe his study, non-focal, banded. Patchy wasn't in there because it didn't reach statistical significance, so we didn't include that. The diffuse patterns we talked about, and diffuse trickling in terms of their rate of progression. So then along comes Lucien Del Prioria, who's written quite a bit of stuff, and he did kind of a mini meta-analysis. I think this paper was about 2018, 2019, something like that, and he looked back through a series of papers written about this subject. And sure enough, he did find, when he collated all the data and did this graph, and he looked at the different groups that had written on this, there really was a merit in what Holtz had talked about way back in 2006. If you had no hyperautofluorescence, slower versus the focal versus the banded, patchy, and diffuse, non-trickling. Del Priore put all those together because he couldn't find any real statistical difference in that banded, patchy, and diffuse group. And then the diffuse trickling had the quickest rate of progression in terms of their GA. So again, you can kind of look at that. You're not going to sit there and study it heavily, but if you just kind of keep the hyperautofluorescent patterns in your mind as you look at the area of GA, it will give you just kind of a general guide whether this patient might be a quick progressor or a slow progressor in terms of their GA. Okay, so treatment, here we go. Okay, I'll talk about pegcetacoplan first just because they were out first, not to slight Izervay in any way at all. Apellis has a lot of data. They have the Philly study, the Oaks Derby study, and they have the Gale extension study. Okay, so they got a lot of data over the last many years here. To Apellis' credit, they didn't cherry pick on this. They looked at different lesion size. They kind of hit the sweet spot in the middle. The fast progressors, they didn't take the very small lesions. They take the very big lesions. We learned small and big are slower progressors. They did take all comers. They took lesions with and without subfocal involvement. They took multifocal lesions, and one of the lesions had to be greater than 1.25 millimeters. And kind of alluding to those same data we talked about from Holtz and Del Priore, they wanted the perilesional hyperautofluorescence, meaning so they looked at a group of eyes that would tend to be quicker progressors to their credit. So, of course, we know that these are both of these drugs are complement inhibitors. The very complex complement system, the classical lectin alternative pathways, converge at C3. And pegcetacoplan works at C3 and C3b. It blocks those, and then all downstream effects from there. And so it's very easy. If you look, there's the slide stack from Apellis goes on and on and on and on and on. But to me, what I really care about is just the end result. I don't really care too much about you can get lost in these percentages. Like I used to tell patients, hey, by the end of 3 years, you got a 42. Oops, that's not what I want. Sorry. You got a 42% decreased risk, but that's really not. This is the one you want to look at. So the every month group had a 32% reduction. The every other month group had a 27% reduction. So real easy. When your patients come in, you can just tell them this is, of course, non-subfoveal, okay? So you say, hey, in general, if you start that drug, you're going to have, over time, over a period of time, in general, you may have about a one-third slowing of your rate of progression with the drug. Subfoveal, not as good, okay, not as good. 21 and 22%, they were equal. Basically, the every other month group was, one percentage better, okay. Well, why would that be? Well, because of what we talked about. Subfoveal lesions progress more slowly, so since they progress more slowly, you're not going to see those lines diverge as much. So, I'll just kind of use an example. I just saw a patient the other day that they were in that 33% group. They presented subfoveal. But they had about 20/50 vision, 20/50, 20/60, and the area of GA was pretty small. So it brings up the point when you look at this data. I mean, what do you do with that person? Do you start treating them every month, every 2 months? Well, and you guys all know this already, but with GA you have to be a psychologist because it's not like Exudate RMD, right? I mean, patients get their shot of Exudate. If they're lucky, their vision goes from way down, way up, and those people are true believers. You're taking people a lot of times have pretty good vision, and you're going to tell them you give them an injection every Q4 to 8 weeks, and you're doing them a favor, and so on. So you have to be a psychologist. So I always see where the patient's at, but in a particular case like that, if I have a 20/50 eye, there's a relatively small subfoveal lesion, I would still urge the patient to be pretty aggressive. I mean, if they want to do Q2 months, they could. As opposed to, but I would go Q4 to 6 weeks. I usually will do 6 weeks kind of in the sweet spot. Now, if they have a big lesion already and their vision's pretty bad, if they still want to treat, yeah, I'd probably just do Q2 months on a patient like that. So how about quality of life? In the Oaks and Derby study, if the lesion was greater than 250 microns in the foveal center, at the end of the Oaks and Derby study, 24 months, those patients actually did have an increased number of letters that they could see on the ETDRS visual acuity chart, versus if they were less than 250 microns, there really was no visual acuity difference. But same thing with that. Does that mean you're going to turn a patient down if they're less than 250 microns? No, because there's incredible variability in the rate of progression. So I would probably mention to patients, if I'm really looking at that closely, that I always tell patients, irrespective of where they're at with this, that it's a race. I say you're either going to win the race or you're going to lose the race. I mean, with the drugs we have currently, sometimes you'll start a patient off, and even Q1 month, I'll tell them, I'll say, this is what it is, you're pretty advanced, and we'll start Q1 month. And unfortunately, some of the patients lose the race. By the end of the year, they've gone from whatever acuity they had, and it's very depressing, but they'll lose vision, meaning that down the line, we'll have drugs that have better efficacy, but this is what we have right now. But I always caution them that if they've got significant disease, and frankly, that's what I'm seeing a lot of these patients are sent over. Sometimes we'll see them, they're pretty advanced already, okay? And that might be one teaching point, I would say, is if you'll monitor these people, it doesn't mean if they come and see us that they have to start treatment, but I think they at least have to have that advantage of possibly being started early and not later if we can catch those people. So again, in the subfoveal group, at 48 months, 1.44 millimeters squared of tissue preserved. In the non-subfoveal group, again, probably something to latch on to, 3.16 millimeters squared of tissue preserved over the 48 months. And let's see, which one is this? The Apellis people like to say, you're looking at 48 months, and then in the lower group, you're looking at the sham crossover group that went from a sham to treatment from 24 to 48 months. They like to say twice the length of treatment, 3 times the tissue, and that's one of their favorite lines. 3 times the tissue saved. That's one of the little things they like to promote. So the longer you're on the drug, the more slow down effect you're going to get. And let's see which. Oh yeah, and this was just out I think within the last week. Now they have 60-month data, and we talked about 32 versus 27% at the 48 months. Really, not really any real big difference. That last 12 months, we're still at 31% on every month. So the data really didn't change in terms of the lines diverging anymore at that point. But this is for non-subfoveal. But now they like to promote the line for 5 years of treatment, a year and a half of tissue saved is the line they published with this one. It's interesting. This is their adverse list here. A lot of patients will make a big deal about the increased risk of choroidal neovascularization. To me, it's a non-issue. I mean, we'll see people that get choroidal neovascularization. I've been surprised how few people end up getting choroidal neovascularization. I don't know if there's something about the complement inhibitors that change the character of the choroidal neovascularization, but the CNVMs I've seen with this are pretty benign. Okay, now is that because the character of it changes, or is it because we're just catching them real early? Because I mean, everybody's I'm OCTing these people like crazy when they come in looking for the early signs. But I can say I haven't seen a single patient lose vision because of new onset choroidal neovascularization. They're on complement inhibitors. That's true for both drugs. The thing they don't have on this, again, this is from Apellis, is the risk of vasculitis, which we'll touch on here in just a couple minutes. So how about Izerva, avacincaptad-pegol? Okay, a little bit more of a newcomer, but we got quite a bit of data on Izerva now as well. So again, it doesn't work at C3 or C3b. It works a little further down the food chain at C5. Okay, does that make a difference? I don't know. The studies are conducted differently, so it is a little bit hard to look at them at apples to apples. So they had the GATHER2 study, and the GATHER2 study, they had a Q1 month group, and then they re-randomized the Q1 month group, and then for 12 to 24 months, they randomized half those patients to every other month. I don't know why they did that. I think it was probably maybe a little bit of political pressure because their study was not ever designed as an every other month group. And then when they started the GATHER2 open extension label, they went back to every month and ran that out to 42 months. And they had a sham group that at month 25 runs up to 42 months. Again, I'm not going to get into trying to parse, and I really can't. The entry criteria, I think that's where it makes it hard because both companies, both drugs had probably modestly different entry criteria, so it does make it hard to look at absolutely apples to apples. It would have been different if they were two drugs and the entry criteria, the lesions were exactly identical, but that's not the situation. So it does make it a little bit hard to compare. So again, all I care about is the top line there, a 28.8% reduction. Now, again, Apellis had 32%, but that was at 48 months. Here we're 42 months. Who knows if they'd run it out another all the way to 48 months, that 28%, 0.8 or 29% might be a little bit higher. But 29%, 31, 32%, I mean, to me, for me at least, that's fairly close. And again, these were non-subfoveal lesions, as was the 31 to 32% quoted by in the Syfovre data. And see what, this slide, I thought about kicking this slide out. They're just trying to make the point that the treatment effect accelerates. Are looking at just month 24 to 42, and you've got a 40.5% reduction. It's kind of a head scratcher. They showed in the sham group that crossed over a 37.1% reduction, not that far off for being just on from 24 to 42 months. I'm just assuming, I don't know, I haven't heard a good explanation. Maybe there's one out there, but I just assume that maybe the lesion criteria in the sham group might have been a little different, and they had an advantage once they started the treatment. I don't know. But it does show, again, that the longer you're on the treatment, the more the treatment effect accelerates. And again, looking at tissue preserved, 2.92 millimeters versus the 3.16 millimeters with the Syfovre. But again, you're talking about 42 months versus the 48 months with Syfovre. So probably not that much different. And again, I think one nice selling point for Izervay, basically the one little bit of concern with after Syfovre was, I should say Syfovre was approved is the concern about occlusive vasculitis. And it is a real phenomena. It's rare. It's like 1 in 4 to 5,000. And if you get it, there's a fairly good chance you're not going to do well. It's an autoimmune phenomenon. It's supposed to happen with the first injection. If I'm using Syfovre, I always inject them in. If they've got one really bad eye, I always give them a test dose in their bad eye. I actually do it twice before I carry it over their good eye, just to be as safe as I can be with the drug. But it is a concern. In the study from Avicen-Kaptead-Pagel, they say no cases of vasculitis. That's 99.9% true. There actually is one case out there outside the auspices of the study where somebody gave a dose of Syfovre in one eye, and then for a Stargardt's patient, and then 24 hours later he gave a dose of Izervay in the other eye, and that patient got vasculitis. Kind of a weird thing, but that's the only known case of vasculitis that there is with Avicen-Kaptead-Pagel, which is a nice advantage. So adjuvant treatment for geographic atrophy, we're just about done here. There's something we covered a few years ago, but it's worth looking at. About 2022, the ARID study number 29 looked at mean GA enlargement rate in those patients who would follow a strict Mediterranean diet, and it did make a difference of 0.256 millimeters square per year in those who would follow a strict Mediterranean diet versus those that were on the West Virginia diet, which I was raised on, which I was raised on, and I still miss, to be honest with you. But it's a feel-good diet. Sure slept well. So there was a companion report. They looked at this, and they did find that higher whole fruit intake, lower red meat intake, alcohol in moderation, monosaturated fat to saturated fat acid ratio made a difference, as we would think. So for those of you that are eating red meat today, just drink enough alcohol to neutralize your GA, and you're going to be in good shape. So interestingly, in that report, they found that if the patient had intermediate and advanced intermediate AMD, that fish made a significant difference. On average, you had to eat fish twice a week, okay? The DHA and EPA in the fish and whatever else had a protective effect. Once they had well-established GA for some reason, fish kind of fell off statistically off the map, but the other ingredients in a strict Mediterranean diet still made a difference in terms of progression. So again, I thought it was a very exciting paper. It just came out in January this year that we'll finish up with. Again, we've all had the experience of the patient comes in, they've already lost one macula to disciform, and they've got they got intermediate or advanced intermediate in the other eye. And I say, Mrs. So-and-so, are you watching? You're not going to get them to change from the West Virginia diet when they're 70 or 80 or 90. Mrs. So-and-so, are you watching your Amsler grid? Oh no, you've never told me about the Amsler grid. Oh, I don't know about that, or they just won't do it. But they say, Mrs. So-and-so, are you taking your vitamins? Oh, I never miss my vitamin. There's some type of pathology out there with that. I don't get it, but no one will watch your grid, but boy, they'll take the vitamins, okay? So this is to me, a big deal. They did find in this January study that ARIDs and ARIDS2 vitamins, they do slow the rate of progression towards the fovea. In the study, they found that the millimeters squared, the overall area of enlargement of GA, was not altered by the vitamins, but it did slow progression to the fovea, which is what we want. So in the ARIDS formula, it slowed it down about 20 microns. In the ARIDS2 formula, it slowed it down about 34 microns. So, and that's per year. Okay, microns not a lot, but when you're adding that up year over year, again, if you can catch these people, between. The bottom line is we just need as many allies as we can. So they're probably not going to change their diet when they're 50 to 80 years old, but they'll take their vitamins. That's just an extra ally on our side, along with the complement inhibitors. Finally, as I talked about earlier, and what we don't have, with exudative AMD, it's immediate gratification. You inject an eye, they come back. they're better. Their B scan is much better, and they're in good shape. But GA is tough because you just don't know if that patient's going to progress. So this is one place where very near in the future we'll have AI helping us make these decisions. There's no doubt about it. There actually is a commercial venture already. I think it's actually put out by Topcon. But it's in conjunction with, it turns out University of Vienna in Austria has done almost all the work with it. They had a bunch of papers they call deep learning papers. They're difficult to understand because they go into the AI aspect of it. But I think this either came out late last year or this year. So this is from University of Vienna, real quickly, and this is it then. They took residents and quote experts, okay, and they had them look at a set of patients, and they had to do several exercises. They looked at OCT, they looked at the FAF, OCT and near-infrared, and then all of them together. And each participant, each doctor in the study, they had to look at like 240 scans. They didn't define over how many patients that was. And then after that, they had a 2-week break, and they had them come back and look at the same set of data, so they wouldn't remember, so there was no bias. And they had to estimate whether they would be slow, medium, or fast progressors on their GA, okay? And they said, okay, we're gonna see how you guys did in a year from now. And then in the model that they have, proprietary model at University of Vienna, they showed the AI model, they showed them one B-scan OCT. No NIR, no nothing. One B-scan OCT, took a second to do, boom. And the mere humans, they lost, okay? Just on that one piece of data, AI was ahead. There were some outliers where they did outperform. But as a group, and interestingly, the experts did more poorly than the residents there a little bit. But as a group, it just and this is just an early AI model. I mean, once this model or whatever gets out there and it learns through multiple clinics and that type of thing, it's all integrated. There's no doubt we're going to have a time in the future where your patient will come in. You're going to be able to predict pretty accurately how quickly their AA is going to progress. Based on what treatments we have, it'll probably predict which treatment's going to be best for them. There's no doubt that's where all this is headed. And that's all I have. Thank you. Yeah. Any questions? Okay. All right. Thanks a lot. Appreciate it.
Give a round of applause for Arnold Nothnagel, Dr. Arnold Nothnagel. Our next presenter is Dr. Sean Platt. Advance, and pointer.
How do I get to the next one?
You just press this one. Yeah.
Will the next PowerPoint automatically come up?
Oh, I'll come back up. I'll switch it up.
All right. Okay. All right. So welcome. I have a few PowerPoints. They're not long. The last one's long, but I have a couple introduction PowerPoints. Real quick. Our practice is pretty heavily involved, and it has been for many decades, in clinical trials. Clinical trials are great because it offers an opportunity for a patient to have access to medication that's not yet available. And in these times where we have had loss of funding for a lot of these medications and they have become very expensive for patients, clinical trials also offers an avenue where patients can get free medication if they're willing to participate. So we have a few recruiting clinical trials I just want to go over real quickly. So we have 3 currently for macular degeneration. The first one, and this is one that we'll go over a little bit more detail later, is the 4DMT, and that is a gene therapy. The Apellis Gallup study, it's a subsequent study to Syfovre, which we all know is FDA approved, but it's also going to be Syfovre intraocular injections combined with subcutaneous injections of a medication that's also a complement inhibitor. And Biogiva, which we don't do a lot of early phase clinical trials, but this is actually an oral medication. And a lot of our patients, well, they're not fans of intraocular injections, so that might be a good possibility for a patient that's really unwilling to have an intraocular injection. All right, and we have a couple of studies for MacTel. If you guys are not aware, after many years of research and just waiting, there is finally a treatment for macular telangiectasia. It's an implant essentially called Incelto, and I believe in the next couple of weeks, our practice will be the first practice, at least in the state of Ohio, to implant this device into a patient, which is huge. We've done them before in clinical trials, but if you're not aware, the Incelto implant is approximately $250,000. Within the last couple of weeks, we've had 2 or 3 patients get approved for this medication, no cost to the patient. Okay, so that's big news as well. And then these are clinical trials that are in follow-up phases. So these are clinical trials that we've already done. We're no longer recruiting, and we're just in the follow-up period. One's a gene therapy. We have the follow-up for some GA studies that we've done for Syfovre. Again, we're not recruiting. This is just more for information and not really patients that we're looking for at this time. And I want to offer this slide if anyone wants to take a photo of it. So these are our research coordinators in different locations, Beechwood, Millbrook Heights, and Youngstown. If you have any questions about any diseases, or if you want to know if a patient would even be a candidate before you refer them to discuss the clinical trials, you can send a message to them. You can go to our website. There are links to their emails as well. Now, we're in Canton, and none of those offices are near Canton, but when we negotiate the contracts for these clinical trials, one thing that we always negotiate is transportation. So if any of the patients from Canton, Dover, Akron, if they're willing to travel to any of these offices, they'll be picked up in a town car or Escalade, whatever they have available, but they'll be picked up, taken to the appointment, and they would be driven straight home. And if any family members want to join them, they're more than welcome to join them as well. Gene therapy summary right there. All right. So before I get into my next discussion, which will be a clinical trial that we have, actually it's about to start here very shortly, I just want to offer a couple introduction slides on gene therapy. What is gene therapy? So very recently, well, I guess in 2017, the first gene therapy was approved for RPE65 mediated inherited retinal diseases. And it's the first FDA-approved gene therapy. Now, gene therapy has been in clinical research for many years, but why did they pick the eye? Well, think about it this way. The eye is almost perfect organ to show efficacy, to get information. It's an organ that has a clear window. You can actually see the response to the medication as simply as looking inside the eye. You don't need an MRI, you don't need an CT, you don't need a biopsy. It's also a small organ, so you don't have to introduce a lot of medication to treat the tissue. And when we're talking about gene therapy, we're talking about modifying the machinery inside of an eye, so your own natural cells to produce a result, right? So if you have cells that rapidly turn over or are going through apoptosis and cell death, well, if you modify that cell, well, it's going to die, and then there's going to be new cells. Well, then you have to reintroduce the treatment to those cells so that you'll get the same result. But think about the retina. These cells are not dividing. They're not regenerating. Those are the same cells you had since birth. So the eye is perfect for this type of revolution because if you introduce these medications into the eye, you modify the machinery inside the cells, and now you have the cells producing a certain result. For Luxturna, it's basically replacing the abnormal gene that the eye has, because you inherited a bad gene, now you got retinitis pigmentosa, right? So now you can modify it where you deliver a certain instruction to the cells, and the cells are now producing the correct protein that that gene was supposed to encode for. And since the cells don't regenerate, then you have a treatment that can last many years. How many years? Well, I guess we won't know for a long time, but a lot of these gene therapies are showing efficacy many years out with great results. So when we're talking about gene therapy, and there's multiple gene therapies in clinical trials for many different inherited diseases, there's a few approaches. Early approaches was to deliver it subretinal, right? More modern approaches is to go into the suprachoroidal space, but what you'll see later on is, well, can we just simply deliver it via intraocular injection? No OR, no vitrectomy, no risk of detachment, endophthalmitis, well, endophthalmitis is always there, but subretinal hemorrhages. And what we've seen with some gene therapies is that the subretinal injection has caused some RPE changes, and has also caused some peripheral field loss too. So if you're thinking about how invasive a procedure is, obviously the subretinal delivery would be the most invasive, where B and C can actually be delivered in the office. So how do we get the gene therapy to produce any result? What is it? Like, what are we doing? As I mentioned before, you're trying to modify your cell's machinery to produce something to get a certain result, right? So how are you going to get that message to the cells? Well, first, you have to design the gene. And the gene is just a recipe for a protein. So in the end, we're trying to produce a protein inside the eye. But you can't just inject the gene in the middle of the vitreous and the cells are going to uptake it. The gene has to get into the cells. So what's the best way to invade a cell? You have to infect it. So the best delivery system that we have to date is to take a virus, take the DNA particles out of the virus, so then all you have is a protein shell. And I think the biggest misconception about viruses is that people think viruses are alive, and they're not. You hear people say, hey, let's kill a virus, kill bacteria. Viruses are just a protein shell with an infectious ability, and that's it. So if you can take the ability of a virus to infect, then now you just have a delivery vehicle. So what you're going to do is that you're going to inject your own DNA, your own gene into that virus, put that virus into the eye, and the virus is no longer going to cause a disease, but it will go into the cell, inject the package into the cell. It will be through endosomes or other methods. It will uptake into the nucleus, and that's where you got your ribosomes, that's where your translation is happening, that's where transcription's happening, and then that cell is going to just vomit out proteins. Well, we're not trying to replace a gene here, but anti-VEGF is a protein. So now you're taking this concept of trying to replace a defective gene into an eye, and you're taking that same technology and you're using it to make a protein such as anti-VEGF. And if you can program your cells to make anti-VEGF, well, then you don't have to keep doing injections every month, 2 months, and so on. So that's the concept that we're presenting here today. And this slide is just kind of showing, how that happens. So you have your viral DNA package, you have your gene, and then it is taken into the cell. And once you get into the cell via endosome, it is going to get into the nucleus, and that's where everything happens. And then in the end, it's going to spit out the protein of interest. All right, so we had to make some questions for these talks, and I made a couple sets. These are all very easy. I don't know if you guys received this yet, but was the first FDA-approved gene therapy. We talked about that. It's going to be B, it's Luxturna. RPE65-mediated inherited retinal disease is the disease that is being treated. How does a gene therapy in the eye reduce need for injections? That's also B. And what is the process of creating vectors for genes? And we talked about that. So basically, what you're doing is you're designing your gene, you're getting it into a vector. A vector is the delivery mechanism, and in this case, we're using viruses. And more specifically, the adenovirus is the vector of choice. And the reason why adenovirus is commonly used for the eye is that the adenovirus has a specific affinity where it does a great job of infecting cells that don't regenerate. So that's why adenoviruses are usually used versus other viruses for retina delivery. All right, so now we'll talk about the clinical trial. Let's see, yeah, that one. All right, so now we kind of know what we're doing here, right? We're designing a gene, we're putting it into a delivery system or an inactive virus, we're injecting that into the eye, it's getting to the retina somehow, and now your retina cells are making anti-VEGF. Sounds science fiction? It's not, it's here. And the 4D-150 Phase 3 clinical trial is the clinical trial that we're about to start. So I'll go through some of the Phase 1 and Phase 2 information. I'll tell you a little bit about the Phase 3, some inclusion and exclusion criteria, and some of the results that we have so far. All right, so this slide, and I've heard this before, a lot of pharmaceutical companies want us to believe that the reason why over time patients don't do as well is that we undertreat. Well, of course they would, right? But there's other things going on. But again, if you look at the data, it may be true because when the patient's looking good, there's no fluid, there's no hemorrhage, we are trying to extend them. We're trying to reduce the burden. But the thought is, are we trying to reduce the burden too quickly? It's possible. I don't know if I believe in it. But we do know if you take information, there's longitudinal studies, there's meta-analysis, the data's all over the place. But what I do believe in is this. Patient has fluid, right? You give them a shot, the concentration of the medication's at its highest, the central retinal thickness goes down. Makes sense. But then it wears off, and then fluid comes back, you give a shot, it goes away. So the patients that have what we call high variability, where they're going through phases of dryness, wet, dry, wet, those patients are more likely to have vision loss over an extended period of time, and they're more likely to have not only greater vision loss, but develop fibrosis. But patients that get injections that don't have a significant reoccurrence of fluid between injections, so we call them the low variability, those patients tend to do the best. So if you have a medication inside the eye that's always there, and you're not having those highs and lows, then we would expect that patients over a long period of time would have better overall vision versus the patients that get injections at different time points. This slide is just showing some PAT surveys. And PAT surveys is a survey that we do at the Academy every year where they ask a bunch of questions of the audience and the retina doctors. And one of the most important things that we tend to think we want for our patients is reduced treatment burden, less injections. And we also want a delivery system that lasts long. We keep increasing the concentration of anti-VEGF, and yeah, we're getting a little bit better result and maybe a little bit more efficacy and durability, but patients are sometimes still receiving a significant amount of injections no matter what you do. And that was in 2018. And after 2018, we have a few medications like Bayview, which cause intraocular inflammation. Syfovre, although very rare, has had some cases of severe intraocular inflammation. So then on more recent surveys, people are like, hey, I want more safety. I want medications that don't cause as much inflammation. I don't want to be worried that my patient's going to get a shot and they may have such a severe vasculitis that they lose their vision, become NLP within a day or two. All right, so let's talk about gene therapy again. I went over this a little bit, how the retina is just a very opportune target for gene therapy. Small tissue, don't need a heavy dose or concentration of a medication. It's stable, non-dividing cells. And the one thing I didn't mention, it's a kind of an immune privileged compartment. You don't want to inject a medication to the eye, and the immune system goes haywire, causes inflammation, and just chews up what you injected into the eye. We know that anti-VEGF is a validated medication, and given that's a protein, obviously that would be a great protein to have the eyes manufacture. So when we're talking about vectors, the vector is the delivery vehicle, right? And there is a catalog. There are pages of different vectors. I mean, you can go and order from a lab whatever virus you want that's inactive, and you can say, hey, that's my vector. But you want a vector that's going to deliver the medication to the retina. You don't want it to stay in the vitreous. You want it to be able to penetrate the ILM, which is a superficial layer of the retina. You don't want it to just bounce off the ILM and just stay in the vitreous, because there are no cells there that are going to uptake that medication and make the protein of interest. So how are we going to do that? As I alluded to, there is a capsid, which is the vector library. But you have your options. You can have the USPS, you can have DHL, you can have FedEx. You know what you want? You want Amazon. You want your package delivered at 4 a.m. Are you awake at 4 a.m.? No. Are you in town? No. But you spend $25 and you can get it at 4 a.m. on a Sunday. That's the delivery that you want. You want to get the best delivery system to where it needs to go. So what we're going to do is that we're going to test each capsid. Well, I don't know how many they tested, but they probably tested a lot. And then you're going to put them into the closest non-human primate, which would be, monkeys, chimpanzees. And then you're just going to see where they go. Unfortunately, you have to harvest the retina to find out where the vector went. But that's just for the benefit of humankind, I guess. There used to be a graph here. So I don't know why it didn't come up, but what you're going to do is, again, you're going to have like survivor of vectors. And then you're going to introduce them into the primate, and you're going to select the ones that have a higher affinity for the retina tissue. So now you know it's going through the vitreous, it's penetrating the ILM, it's getting to the retina tissues. And then you're going to isolate those, and then you're going to put the winners into another primate. And then you're going to see which one gets the farthest or gets to the target that you want. Then you're going to isolate those winners, and then you're going to have them go against themselves again. And so you're going to do multiple rounds of this, and then in the end, R100 was the winner. So for this delivery system, they have what they consider the best vector for the result that they want. So now you know what the gene is. You want a gene that makes anti-VEGF. The anti-VEGF in this study is Eylea. This medication will deliver Eylea to the eye. On top of that, it will also deliver VEGF-C. Now, we don't know much about VEGF-C. There has been some clinical trials of late that have looked into anti-VEGF-C antibodies. But when I was at the meeting for this specific clinical trial, what I was told is that they did some experiments with just Eylea, and they did some experiments where they had Eylea and this VEGF-C trap, and they noticed that the results were better by adding the VEGF-C ability. So this medication is Eylea with a little extra on top. So when we give an injection of an anti-VEGF, it goes into the vitreous. But where's the biodistribution? You get a little bit in the aqueous humor, but most of it stays in the vitreous humor. And very little of it, as you can see where you see the R and CA, so it's going to be the retina choroid, very little of it gets to the retina and choroid. Obviously, some does, or else we wouldn't have an effect, right? But the 4D150, you inject it, and see where it's the darkest blue, it's going to be more in the choroid. It's going to be in the retina. And the smallest concentration is going to be in the front part of the eye where we don't need anti-VEGF. And if you look at the pharmacokinetics, When you give a shot, concentration goes up, the eye breaks it down over time, give another shot. So your concentration of anti-VEGF is going up and down, up and down, up and down. But if you have your eyes making Eylea, you can give one injection, the concentration of VEGF hits a certain point and then plateaus. All right, so this is going to be discussing the first early phases of clinical trials for DMT, and we're in phase 3 right now. And if you look at the numbers, early phase clinical trials, they don't have a lot of patients, okay? So when we're looking at the numbers, just remember, the number of patients that were in each subgroup or group is going to be quite low. So in phase 1 and phase 2A, what they did is that they took some of the eyes that had the worst disease burden. These are patients that on average had 10 or more injections a year. Imagine that. So you're pretty much getting an injection once a month. And the first phase is they're just trying to see what dose does the eye tolerate, is it safe? Phase 2A, they're taking the winners of phase 1 essentially, and then they're comparing it with Eylea. So they had 10 patients in the Eylea group, they had 21 in the 1 to the 10th concentration group, and they had 20 in the 3 to the 10th concentration group. And phase 2B, then they took those two concentrations, and then they, instead of using severe disease activity, they just took patients that are getting 6 injections a year. So their disease burden is not as high because they want to show how does this medication work with the worst of the worst, and then how does this medication work with just your general population. This is showing just the demographics, and you can kind of see that they try to keep the ages about the same. So you want more of an even distribution of your demographics, so you can show in comparison that you have a similar group in each arm of the study, and similar characteristics here. Okay, so this is the severe disease and burden group. You see all these Skittles right here? Those are each injections. Various injections, but those are all injections. And each line is a patient, right? So you can see, especially this patient basically had an injection once a month. But these are eyes that receive a significant amount of injections. And then when we get to this line, right there, that's going to be the 4DMT, or 4150. Look at the patients in the top rows. After they got that injection, again, this is the worst of the worst. Look at how many patients did not receive another injection over 52 weeks, 1 year. 44%, okay? Now, as you can see, as we get towards the bottom, not every patient was injection-free. And again, these eyes are the worst of the worst, but you can definitely tell that you're seeing a trend where the injection burden was reduced, especially this guy right there. Still received a lot of rescue injections, but again, less than they had for the year prior. 52% of the patients in the severe disease group had 0 to 1 injections after 1 year, after getting that one shot. I think I'm missing a slide. Oh, no. Okay. These slides are just showing, compared to Eylea, kind of the trend. We're looking at change in visual acuity. The dark solid blue line is all the eyes that got the 4DMT, and then they extrapolated that to show the dotted blue line, where those are the patients that were injection-free over a whole year, which was only 10 out of the 24. And then they're also showing the patients that got the anti-VEGF. Nothing profound from this slide, but look at the central retinal thickness or the central subfield thickness. The yellow line is the Eylea. Look at the thickness. It goes down, it goes up, it goes down, it goes up. Remember, high variability, worse vision over time, okay? So this is the other group that I mentioned, the broad population group. So they weren't looking for the worst of the worst. They're just looking for patients that we would see in clinic. Just kind of a nice mixture of patients with mild disease, severe disease, and everything in between. Now, less Skittles on this side, less injections, but look at after they received the medication. 70% of the patients did not receive more than one injection after a whole year, okay? Yeah, except for this one right here. I don't know what's going on with them. Yeah. All right, so similar trends, because now you have a stable amount of medication inside the eye, you have a continuous supply of anti-VEGF. You have a very linear line where you have improved letters on the eye chart, but you don't see it drop towards the end of the 52 weeks, where if you had an eye that had a lot of variability, over time you might see that the trend is less letters. And look at the central retinal thickness, just what we would expect to see if you have a constant, steady supply of medication, that you're not going to see the central subfield thickness go up and down, up and down, up and down. So then there was another subgroup that they did, and they're looking at patients that just recently converted to wet macular degeneration. So now these are the newly diagnosed patients. And you can see that some of them only had 1 or 2 injections before they got the study drug. But look at how many patients, if you treat them early, did not get another injection over 1 year. 87% of the patients, and again, this isn't a big number of patients, right? But just keep that in mind when we talk about this, because we don't know if this would actually correlate with real life when we're talking about thousands and tens of thousands of patients. But in this trial, 87% of the patients in this subgroup did not receive another injection or had 1 injection only within a year, which is pretty amazing. We've looked at these graphs before, similar trends that you would see. So let's talk about safety. So safety is huge, especially as retina specialists. You have a medication that works very well, but then when you also know that the medication could potentially blind someone, it's tough to make these decisions. And actually, some places will refuse to use the medication at all if they are associated with any type of severe inflammation, whether it's during a clinical trial or after the medication is FDA approved. So this is taking all the patients at their visits, and they were looking for inflammation, right? So this side is going to be anterior chamber cells, and that side is going to be vitreous cells. So out of all the patients, you had 2 patients that had anterior chamber cells. One was a patient that had cells after cataract surgery, so that's associated with cataract surgery, not the medication. And that red box right there, the patient had 4+ cell, they had endophthalmitis. And that was actually due to an Eylea injection and not the actual 4DMT. And looking at vitreous cells, you can see in the top right, that patient is the patient that had endophthalmitis, so obviously they had vitreous cell. So again, that's related to an Eylea injection. And then you have 2 light green boxes where there was 1+ cells in 2 patients. Now, those 2 patients, they didn't do anything, but that 1+ cell resolved by the next visit. All right? All right, so what can we say about the 4D-150? There's about 3 years of follow-up, some patients, especially patients from the phase 1 studies. It was well tolerated. They are saying that there is no serious adverse effects. And if you look at that chart, I would agree. They had no hypotony, no endophthalmitis due to the medication. But again, endophthalmitis isn't caused by the medication. It's caused by the fact that you put a hole in the eye. So that's always going to be a possibility no matter what you inject into the eye. I can inject sterile water and you can get endophthalmitis. There was no retinal vasculitis. There was no choroidal effusions. There was a couple of patients that had a little bit of cell. It was 1+ cell, went away spontaneously, so that's 2.8% of the patients. And I don't think I even mentioned this, and you'll see it more in the phase 3, which is the study that we're doing now. Patients, after they get their anti-VEGF injection, so that you start off with a couple rounds of Eylea to show that you respond to anti-VEGF, but then you have to do a dose of Durezol or a steroid before and for a while after getting your intraocular study drug. So this is just a case study, and obviously this case study is going to look amazing because why would you show a case study if it didn't look great? So you have a patient, subretinal fluid, diagnosed with wet macular degeneration, and gets the study drug, gets a little bit better. Week 8, no fluid, no fluid, no fluid. That's what you would expect. After 52 weeks, no fluid. But the central retinal thickness, which is the light blue line, went down and stayed down. It's almost a completely flat line. The patient's visual acuity increased a little bit, but by the time you get to the end of the 52 weeks, is about the same. And this is an eye that probably would have pretty good visual acuity on presentation anyways. There you go. All right, so this is just a summary of what we mentioned before in the early phase 1 and phase 2 study. Severe treatment burden, 52% did not have more than one injection after a year. And then in the broad population subgroup, 70%, and then you get the patients that are recently or newly diagnosed, 87% reduction, or injection-free, 0 to 1, 80%, sorry, 0 injections, 87%, 0 to 1 injection after a year. So summary, again, 4150, well tolerated, up to 3 years. These new batteries. Okay, so now that was then, now we're in phase 3 clinical trials. So this is generally the last phase of clinical trials before it goes up to the FDA and becomes real life, okay? Right now, again, it's kind of sci-fi, and it's just amazing technology that we can't even do anything like this. And now our practice is delivering this very technology to patients. So if you have a patient that has new macular degeneration, keep us in mind. The phase 3 clinical trial is separated into 2. So you have the North America subset. They're looking for 400 patients. Unfortunately, every patient has to be treatment naive. That means they've never had an anti-VEGF before, okay? The rest of the world is a little bit more lucky, where some of them can have actually had anti-VEGF before, but most of them also have to be treatment naive. So we have to get the newcomers. All right, so this is the way the trial is designed. So you get the patient, you see them, you diagnose them. What are we going to do? Well, number one, you're going to give them an anti-VEGF, because if the patient's not responding to anti-VEGF, there's a couple things to consider. Your diagnosis is not correct, or they just don't respond well to anti-VEGF, and their information is not going to be very helpful when you're kind of looking at controlling the disease. So you get 2 anti-VEGFs, and what they want to see is that they want to see a 15% reduction in central subfield thickness. That's a lot, honestly. But to even qualify for the study, you have to have like 500 micrometers of central retinal thickness. So in the study, and most good studies, you have to have a rescue. In this study, there's a few criteria for an Eylea injection after, if you receive the study drug, 4150. Now, if your central subfield thickness increased more than 50 micrometers, or you had more than 5-letter decline in best corrected visual acuity, you can get a shot of Eylea. More than 10 letters lost, and you're saying it's due to wet macular degeneration activity, you can get an Eylea rescue. If your central retinal thickness has nothing to do with the vision can be the same, but if it's over 100 micron increase, you can get an Eylea. Or if there's a subretinal hemorrhage, or any type of hemorrhage, honestly, and it's at the discretion of the study, the PI or the medical monitor, you can do an anti-VEGF rescue injection. All right, and it's a very similar design for the global study. And you can see at the top of the graph that Durezol 20-week taper. All right, so what's the primary endpoint? So they're looking at the change of the baseline, the mean change, and best corrected visual acuity per the DRS letter score. And essentially what they want to show is that their medication is not inferior to Eylea given intraocularly at whatever interval, right? And there's some secondary endpoints, but we won't go through each one. All right, so as I mentioned, treatment naive. So what's some of the inclusion criteria? So what do these patients have to even be considered for this study? So the total size of the CNVM essentially has to be less than 9 disc areas on the FA. The CNV component of this lesion can't be, or the CNV component can't be more than 50% of the total lesion size on the FA, and there has to be some fluid on the OCT. Now this is very important because I've had a couple of patients not qualify because their vision was too good. They were 20/20, but your vision has to be between 20/32 to 20/320. All right. The central retinal thickness or the subfield thickness has to be over 500 micrometers, which, I mean, I think that's a lot. And you have to show a clinical response to the anti-VEGF, which is why you get the Eyleas before you get randomized into, well, the Eylea group or the 4D-150 group. Exclusion criteria. So, and this is just a comprehensive list. There are other things like, if you have terminal cancer, you can't be a study patient because you might not be able to stay around long enough to get the end result, right? But if you have any history of inflammation in the eye, I'm not talking about like a little, episcleritis or anything, but true intraocular inflammation or active inflammation, and they do say periocular, but again, I guess it's always going to be up to the study whether they want to let a patient in. But they're trying to be safe. So if you're just a pro-inflammatory person, you might be at a high risk of actually causing some inflammation. So you can't be in the study. If you have any eye condition or a surgical complication that could decrease your visual acuity that has nothing to do with the medication, that would skew the results, can't be part of the study. If you've had previous medications or even gene therapy or systemic therapy such as Avastin for chemo reasons that inhibits VEGF pathways, you can't be part of the study. Prior gene therapy, I just mentioned. Subretinal hemorrhage, atrophy, fibrosis, obviously, it's unlikely that your vision would qualify, but if it does, it could skew results. And if you are known to be a steroid responder, because you're going to be on Durezol for 20 weeks, you are excluded from the study. All right, so the North American study, 400 patients, all treatment naive, where the global patients, 60% can be treatment naive, 40% can be treatment experienced, which just means they've had anti-VEGF injections before. And you have to have a 15% decrease in central subfield thickness with anti-VEGF to be considered for the study. Okay. All right, so a couple questions based on this set of slides. Again, it's pretty obvious. What's the primary objective endpoint of the Forefront Phase 3 program? If you notice a trend, this is also B. But then I try to trick you guys. And so the next question, which of the following is a key characteristic of the 4D-150 gene therapy? And for this one, I picked C. All right. So that's the end of that PowerPoint. I guess I'll offer up some question time. Anybody? Yes.
What's your retreatment criteria in the first three? Oh, hi.
Yep.
What is your retreatment criteria? Is it the same as usual criteria for retreatment?
Are you referring to the rescue if they have? Yeah, thank you. Appreciate it.
In the first stages, the two be before this
Oh,
phase
the
3.
phase 1. Oh, I'm not sure. I'm not sure. So those studies are more safety efficacy studies. I suspect it's probably the same rescue criteria that we're using in 3, but we didn't participate in any of those studies, so I can't really tell you for sure offhand.
What's the plan on the steroid responders? As patients don't often know that they're steroid responders.
So if they have a known history, they are automatically excluded. But to your point, most of the time we don't know until they get a steroid. And Durezol, I mean, it's a pretty heavy hitter, right? So now, if they are a steroid responder and the pressures are running too high and they can't finish the 20 weeks, obviously there would be a discussion with the study, right? Some of the patients, and it was alluded to in another slide, they didn't finish the Durezol, okay? At what point would you have to exclude them from the study if they can't do the Durezol at all? You know, those sort of offshoots, you know, those would have to be discussed. But you can also treat the high intraocular pressure as well. And so we're not excluded from doing that. So we'll put them on drops. I mean, obviously we don't want to induce glaucoma, right? Yeah, thank you.
You're using the steroid to decrease the immune response to the actual injection?
In a way, right? So one of the biggest issue with intraocular injections with these new medications is that patients are showing what they call IOI, or intraocular inflammation, and that gets everyone really uneasy. So right before they get the medication, they're started on that steroid, the Durezol. And then they're on that Durezol for a period of time. Now, whether that is a prophylactic move or they notice that there was inflammation in early phases of the clinical trial and they're trying to curb that, increase the safety profile of the medication, whatever it may be, then that's how they would design the subsequent studies based on the information they got from the previous studies. But yeah, that's a good question.
So do we understand the mechanism of that?
The inflammation?
Yes.
Basically introducing a foreign substance into the eye, right? Not everyone gets it. And we know with other medications like Syfovre, and I have to tell patients, you have a 1 in 10,000 chance that you can have a very severe intraocular inflammatory process that could potentially lead to vision loss, substantial vision loss. Now, are patients that have an autoimmune history or a history of previous intraocular inflammation, are they more prone to get it? I mean, I think intuitively you have to think so. And if I have a patient that has a significant intraocular history, I might not suggest that medication for them.
And that reaction doesn't continue because?
Which reaction?
To the injection. So you get the injection of the 40, 150?
Yeah. Mm-hmm.
And then you don't get a reaction after 20 weeks, we assume? Or the initial? It's only the initial?
Yeah, so the patients that had inflammation that was associated with the medication, so we had one patient that had inflammation because of cataract surgery. There was one patient that had inflammation due to endophthalmitis from an Eylea injection. So those are not due to the medication. 2 patients had 1+ vitreous cell after an injection, and it spontaneously went away. Now, if you look at the timing of that was more towards the front end of their treatment, so more than likely they might have still been on that Durezol taper. But they made a point to mention that it spontaneously went away. That's all we know. Yeah.
Thank you.
You're very welcome. All right. Anyone else? Okay.
All right.
All right, thank you.
Thank you, Dr. Platt. Okay, our next speaker is the newest member to Retina Associates of Cleveland. Please give a round of applause to Dr. David Shieh.
All right, thank you everyone for coming. Those were excellent talks by Dr. Nothnagel and Dr. Platt. Very cutting edge stuff, the forefront of retina. I'm going to kind of take a step back and, go to something a little bit more basic, just a refresher on interpreting OCTs. I'm very glad to be here. This is my first job out of fellowship, And, I just wanted to introduce myself here. I grew up in New Jersey. I did college and med school up in upstate New York, and residency here in Cleveland at Case Western. That's where I met my now wife, and we spent some time apart in fellowship. I went down to Texas for some reason, and then made the right choice, came back, and happily newly married as of this summer. So these are some of our pictures from our honeymoon. Thank you. Now I work at Retina Associates. My locations are over here. I spend a fair amount of time in Canton, about 1.5 days a week, and I operate over at Vista. So very happy to be here. The objectives of my talk are to describe the background interpretation and example pathologies using the following imaging modalities of OCT, infrared fundus photography, and OCT angiography, and to review the applications of these imaging modalities in some, a sample of some diseases like dry AMD, diabetic retinopathy, and hydroxychloroquine toxicity. So I just wanted to kind of straw poll of everyone here who has OCT and regularly uses it in their office. Also, I would say the vast majority. And then how about fundus photography? Kind of the same amount. Okay, good to know. Yeah. So going back to the kind of the basic science of OCT, uses infrared light, 840 nanometers, and basically using the interference of two beams of light, an object beam and a reference beam, which is projected to a mirror with a known distance from the object. We can kind of determine the reflectivity of structures and also their distance from the scanning machine. These are compiled into A scans, which are single dimension, and B scans, which are two-dimensional images. And then modern machines can acquire, hundreds of thousands of images per second. So, very, very efficient and, kind of a mainstay, excuse me, mainstay of our clinics at this point. So, OCT technology started with time domain OCT, kind of involving moving mirrors and, very slow scans. But they've now evolved to, the two bottom types of OCT that we see here, spectral domain OCT, which is the, probably what most of us have in our offices, and swept source OCT, which is kind of, more research, used more for research at this point. As an aside, enhanced depth imaging is also another mode of the spectral domain OCT that allows deeper imaging into the choroid, allowing for a measurement of choroidal thickness, which is useful in our diagnoses of central serous retinopathy or other pachychoroid disorders. So this is just a review of our retinal anatomy. We see these, dozens of times a day, but just as a reminder, the macula is composed of many different layers of cells, kind of arranged in an alternating order of axons and cell bodies, and that's what gives our different reflectivity of the bands of our OCT. So I won't go into this too much more. This is a nice reference picture of what the layers are that we should be seeing on a normal OCT. How many of you see this kind of OCT, more than 50% of the time? Is it? Yeah? Okay. Yeah. It's great to see a normal OCT, and it can tell you, frankly, a lot, even if you're not looking particularly at the retina. If you're looking for a PVD, things like that, OCT is actually, quite useful. When I look for pathology, a lot of times looking at the outer four kind of hyperreflective outer retinal bands, and starting from the inner retina, the innermost of these are the ELM, the thinnest band, and then followed by the ISOS junction, also known as the ellipsoid zone. this is kind of a very high yield area to look at. Especially in patients with unexplained vision loss, with no fluid, no other anatomical changes, you have to look very closely at the ellipsoid zone. Following that, there's the interdigitation zone, which is kind of in the middle, sandwiched between the ellipsoid and the RPE. I find that this layer, can tell you a lot, but oftentimes it can be missing in even normal OCTs, just depending on the quality of the scan, because in order to resolve that layer, some patients' media opacities may get in the way. And then finally, we have the RPE, which is the brightest, thickest band, obviously very important as well. When we're describing OCTs, we have, basically, if it's bright, we call it hyperreflective, dark, hyporeflective, and then a few other things. Shadowing, when something in front of the object is too reflective, then that results in hyporeflectivity of the layers below. And you can see this very often with blood vessels. When you have a brightly reflected blood vessel, that will shadow the underlying structures. On the other side, there's hypertransmission. When something in front is not as reflective as normal, that'll result in brightening of the layers below. And you see this most often in areas of RPE atrophy, like Dr. Nothnagel was talking about, very important precursor to GA. So this is something to definitely look out for. Hypertransmission defects. 250 microns is kind of our cutoff, these kinds of drusen lesions are very high risk, and it's an ideal kind of time to start the conversation about GA treatment. Some special features of the macula that we see on the OCT, the RNFL, obviously it's thicker nasally, so if you're just given any random OCT, you can kind of figure out which eye it came from, unless of course they have glaucoma. There's the outer plexiform layer, or Henle's fiber layer. The Henle fiber layer represents the photoreceptor axons of the perifoveal region. It's kind of unique in that it's oriented radially and obliquely, and that causes it to have some interesting optical effects like birefringence. It's also responsible for the petaloid appearance of cystoid macular edema when you look at it on a fluorescein angiogram. Just an aside on infrared fundus photos, this is basically using the same wavelength of light that's used to generate your OCT B scans, it's just given to you as to give you a better idea of the retinal anatomy and gross anatomy of the macula. It's similar but not quite the same as a red-free photo. And since the wavelength is a little bit deeper, infrared helps image deeper retinal structures like RPE and drusen, and it's quite helpful for judging geographic atrophy as well without having to order a separate autofluorescence. In both kinds of images, the disc appears gray, and you can see some features of the disc. In both, RPE defects appear bright, both infrared and red-free photography. So I just wanted to go through some example OCT pathologies by layer. So starting at the vitreoretinal interface, we have the first picture on the top here is a partial PVD. I would call this stage 2 to 3, that's detached from the macula, but still attached at the nerve, so not quite a complete PVD. We don't always get this kind of long scan through the nerve, but it can be helpful if you're quite a little bit equivocal about the status of the PVD. Second is ERM. You can see very clear kind of white line over the inner retina, and then VMT. VMT is kind of a precursor to macular holes, which we see the 4 stages of macular holes here on the left. Stage 1, where there is still a kind of inner retinal roof attached to the VMT. Stage 2 is when you have a roof with kind of an overhang over it, but it is, at that point, a full thickness macular hole. Stage 3, when the macular hole enlarges and, there is no kind of overhanging roof. and then stage 4 when the PVD is complete. Related to full thickness macular holes are lamellar macular holes. Lamellar holes, and they're kind of, I would say they're kind of on a different pathologic spectrum from full thickness macular holes, even though they share a very similar name. The surgical prognosis is a lot less certain. Lots of these patients don't even need surgery, and whereas I try to convince patients into macular hole surgery, I try to convince patients out of lamellar hole surgery unless they're really, really asking for it. And you can really tell kind of a lamellar hole by the epiretinal proliferation, that grayish tissue that is there kind of in where an epiretinal membrane would be. This epiretinal proliferation is a very kind of spongy, gummy tissue that's a little bit difficult to peel and doesn't actually cause too much traction on the retina. And then finally, at the lower right-hand corner, we have a pseudohole, which is related to epiretinal membranes, just related to the tangential traction, and not actually a macular hole, although they have similar appearance on fundus exam. Going in more into the inner retina, we have our retinal vascular disorders, since the retinal blood vessels supply the inner third of the retina. We have inner 2/3, I'm sorry. Retinal artery occlusion and retinal vein occlusion. And, none of us want to see, either of these very often, but, there they are. Further into the inner retina, we have, a special type of CME. This is actually glaucoma-related microcystic macular edema, which is somewhat rare, although, you'll see it in kind of your end-stage glaucoma patients. And this is kind of one of those macular edemas that really does not require treatment. It's interesting to see, but as you see, it doesn't really distort the shape of the retina at all. Going into more classic types of CME, we have the non-leaking forms and the leaking forms. Most commonly diabetic macular edema, pseudophakic macular edema, uveitic, and RVO related. Kind of related is, you can also see cystic changes in the macula in MACTEL type 2. Like Dr. Platt mentioned, there is now a new treatment for MACTEL, the Incelto surgical implant. It's pretty promising, very exciting at the time. Going more into the middle retina, we have kind of a little bit more unusual pathologies. PAM, or paracentral acute middle maculopathy, which is a vascular kind of vasospasm-related disorder. You can see here in this bottom left scan here, the hyperreflective bands in the middle retina, it's kind of related to vascular disorders. Can also be seen in people who use cocaine with the vasospasm associated with that. And then we have neuroretinitis, which I included in the middle retina slide because of its propensity to cause a macular star as it exudates into the Henle fiber layer, which is kind of responsible for that radial pattern. Going out to the outer retina, this is kind of where the bulk of retinal pathology that we see in clinic exists. There's the AMN, acute macular, I forget what the N stands for, but it's something like that, and macular ischemia. So, these, represent abnormalities in the outer retina, and like we saw in the example slides, those outer retinal bands, as they become disrupted, those are very, very visually significant. Also in the outer retina, we see some more unusual diseases. On the left-hand side, we have cancer-associated retinopathy. This is a condition, hopefully, you don't see very often, but can present almost like a, RP-like picture in very elderly patients with retinal arteriolar narrowing and just diffuse atrophy of the outer retina. And then a little bit more classic picture, hydroxychloroquine toxicity. This picture here is kind of on the more severe stages with a classic bullseye maculopathy and a flying saucer in the fovea. So I just wanted to kind of give an update on hydroxychloroquine screening recommendations. I imagine this is something you see quite often, and my picture cut it off, but there's actually an update out from the AAO just as of this month with some revised recommendations. Basically what's new is that the primary tools being recommended for screening are now OCT and fundus autofluorescence. Visual fields and multifocal ERG are no longer recommended as first-line tests and are instead recommended as secondary confirmatory tests. We also have kind of more data on stabilization or reversal of toxicity, which is possible if detected at the earlier stages, basically before the ELM is disrupted or lost. And we can see kind of in this timeline here, this is by no means every patient has to follow this timeline, but it usually takes more than 10 years of treatment to reach this level of toxicity, and even then, really only very, very slow changes, which can first be seen in the ellipsoid zone and interdigitation zone becoming kind of modeled. They did point out that as we become more sensitive in the detection of very early toxicity, the decision of when to stop the medication becomes a little bit more difficult because a lot of these patients, the hydroxychloroquine is otherwise a very good medication, and they were diagnosed with autoimmune disease in their very young years. So we have a lot of patients on hydroxychloroquine for many years, that's something that definitely needs a little bit further discussion on the risks and benefits of the benefits of this medication versus the need to stop it and prevent further toxicity. Things that are unchanged, the recommended dosage is still about less than or equal to 5 milligrams per day per kilogram of real weight. More risk in older patients with renal disease, or on tamoxifen. And Asian patients tend to develop toxicity outside the macula, so important to look beyond your standard macular OCT at the fundus autofluorescence and at the exam. And then they recommended baseline screening at initiation of hydroxychloroquine treatment, followed by annual screening, which can be deferred for the first 5 years in low-risk patients. This slide here I included just because I found it interesting. I don't really think about the the kind of correlation of the anatomy with patients' visual fields, but when you look at a 10-2 visual field, you're really only kind of looking, not even the borders don't even extend outside of the macula, whereas even a 30-2 field, really you're not really getting too much out into the periphery. 30-2, you're looking at 1 or 2 disc diameters outside the arcades. It kind of brings into question how much of the peripheral retina is really useful at all. But those are kind of, a nice correlation to, what you're seeing on your visual fields and exam. Like I said earlier, the earliest signs of hydroxychloroquine maculopathy come in the outer retina in the parafoveal region, most commonly in Caucasian patients. This ellipsoid zone and also the interdigitation zone you can see here. Even if the ellipsoid zone kind of appears equivocal, once you start seeing, or not seeing the interdigitation zone in the parafoveal region, that's when you should start to probably become a little bit suspicious of early plaquenal maculopathy. Oh yeah.
What would you recommend for those of us who don't have FAF?
Yeah.
Screening now with the new standards.
Yeah. So, well, I would say, it's a good question. It's definitely fundus autofluorescence. I think was recommended more because it allows you to, capture, both groups of patients, the patients who get, central parafoveal lesions, and also patients who get more peripheral toxicity. I would say, still following the older recommendations of getting 30-2s for, Asian patients and 10-2s for, Caucasian patients, that probably is still sufficient. Although, it's I would say, probably, there's probably a low risk of missing something with if you're following someone closely. Yeah. I also wanted to brush on pentosan maculopathy as we're talking about toxic drugs to the macula. This is a disease that's somewhat newly described within the past 10 years or so. Pentosan, brand name Elmeron, is a drug that's used for interstitial cystitis and bladder pain syndrome. And it causes a very distinctive pigmentary retinopathy, which increases as you increase in cumulative exposure. So, this was kind of a very hot topic, a few years ago, but still important to consider if you have a patient with, a strange kind of AMD-like but not quite fitting the correct demographic, to ask about their medication list. Going back to our OCT pathology by layers, this is a kind of, a little bit of a curveball here, but you have this patient here with kind of a very wiped out outer retina. You don't really see any ellipsoid zone here. The RPE looks kind of very mottled looking, and even the outer nuclear layer is very thin. And you look at the external exam and you see this, kind of a foamy white spot on the conjunctiva. So, this is a vitamin A deficiency. And we probably don't see it too much in Ohio. It's the leading preventable cause of blindness in children worldwide. But in, well-nourished populations, it's a little bit more rare, but can even occur in the developed world, especially in patients who have had bariatric surgery. Vitamins A, D, E, and K are absorbed by the duodenum, the first gut segment of the bowel. And that's very commonly affected in, gastric bypass patients, maybe a little bit less often now that we have Ozempic. But, patients with intestinal inflammation, liver disease, my slide's kind of going out of order here. But, patients with, stomach problems and, outer retinal atrophy kind of need to get clued in to vitamin A deficiency because it is reversible, fortunately. As we go into the RPE and choroid, we see our typical AMD, dry AMD with soft drusen up at the top, dry AMD with a drusenoid PED and pigment migration in the middle, and then geographic atrophy at the bottom there. Going into kind of the more exudative forms of AMD, we have wet AMD with intraretinal fluid, wet AMD with a serous PED and subretinal fluid. You can tell it's serous by, kind of the hyporeflective core of the PED. And at the bottom is actually a hemorrhagic PED, which, on the OCT kind of almost looks a little similar to the serous one. But, that's mostly because of the shadowing effect of the very hyperreflective blood at the top of at the most inner part of the PED. It's kind of shadowing and causing a falsely hyporeflective appearance of the core of the PED. But, on exam, it's quite a bit more obvious. Let's see. Here we have, on the left, we have a wet AMD with a disciform scar, and then CNVM due to ocular histoplasmosis. Really not really a great way to tell just by an OCT, but given the right clinical history, can also cause quite difficult to manage CNVMs. Looking into the three different types of pigment epithelial detachments, there are drusenoid, serous, and fibrovascular PEDs. The fibrovascular type is, of course, the most concerning when we look for CNVs. I included myopic maculopathy here, or pathologic myopia here, just because it's also a quite common cause of CNVMs. But myopia can cause myriad different forms of vision-threatening retinal disease. Here at the top, we have myopic macular schisis, which is amenable to surgery, especially, if subretinal fluid starts to develop. And then at the bottom picture, we have a myopic CNVM with subretinal hyperreflective material and a cuff of subretinal fluid. Notable here is the thin, very stretched out, layers, all layers of the eye really, but including the choroid. Here's a spectrum of diseases that I alluded to earlier, the pachychoroid spectrum. There are many pachychoroid spectrum diseases that are constantly kind of being described, but the three kind of classic ones are pachychoroid pigment epitheliopathy, which is the most mild form, also known as form Frust CSR. Then there's a central serous chorioretinopathy and PCV, which is the kind of more AMD masquerade variant. But all three of these diseases share in common a thick, abnormal choroid. PPE, I don't diagnose very often, but in patients with, atypical-looking drusen who are too young really to have AMD, it's helpful to look at the choroid and see if it's abnormally thickened. If it is, that's kind of, that may be the diagnosis. Usually does not, mean much clinically, but PCV is, a disease that I personally am interested in because it kind of masquerades as, your more typical AMD with certain, interesting features. You tend to get more sharp peaked PEDs with PCV, and it tends to affect a little bit of a different demographic of patients, Asian and African American patients, and a little bit more difficult to treat with anti-VEGF, a little bit resistant to treatment. But again, shared features of the pachychoroid spectrum, a thick choroid, general consensus is about above 300 to 400 microns in the subfoveal region. There are pachyvessels in Howler's layer, one of the layers of the choroid, and choroidal hyperpermeability on ICG angiography, which admittedly we don't get often. Again, these tend to be less responsive to anti-VEGF, and PDT can actually be a little bit more useful than compared to in standard AMD because of the root of the disease in the choroid. I wanted to touch on OCT angiography, which we're doing quite a bit more frequently these days. You can think of OCT angiography as kind of a movementagram. It really is looking for things that are moving, namely red blood cells. So multiple scans are getting taken in the same area, and differences are analyzed over time to kind of infer areas where blood is flowing in the retina. It's nice in that it's non-invasive and very useful for CNVMs of any type in the macula. AMD, PCV. It's not quite as helpful for identifying PDR since really the standard OCTA only captures within a small area of the retina in the central macula. But it's quite useful for detecting occult CNVMs, things that are not quite visible on our exam or even on the OCT. If you're suspicious of this PED, get an OCTA through it, and sure enough, you can find a net of blood vessels. So pretty cool. Now, kind of a case study in the usefulness of OCTA, kind of a common question that we might have does this patient with central serous retinopathy have a secondary CNVM that would benefit from injections? So we kind of see here, there's a little bit of suspicion because this PED has what's called a double layer sign. Basically, 2 layers with a kind of grayish core in the middle, which can hint that there's a CNV there. The FA and ICGA can be kind of equivocal in these cases because CSR can also leak just by itself. But the OCTA has, kind of lights up this neovascular network in picture G there. When you adjust the segmentation to cover the area between the RPE and Brooks membrane. So can be quite useful in the right settings. Now OCTA does have its limitations. This is an OCTA that I got just a couple days ago, but basically, it's a very, the segmentation, to allow you to pick out the retinal layers, that's all built on, a relatively normal retinal anatomy. So especially in patients who are difficult to position or with very structurally abnormal retinas, the OCTA just cannot figure out which layer the blood vessels belong to. It also cannot demonstrate active leakage, which is important when you're trying to target focal laser or assessing posterior uveitis, or even just trying to figure out if a CNVM is actually leaking or not. And finally, at current stages, there's kind of a lack of ultra-wide field imaging, which prevents us from using it a little bit more, as a tool for diabetics. I wanted to show this picture here. This is also a patient that I saw in my first weeks of practice here. Does this patient look like they have diabetic retinopathy? Anything kind of jump out to you? Not really, right? But when we do an FA, it's quite apparent that they actually have PDR. So even this relatively bland fundus can trick you sometimes, and OCTA won't necessarily help you with that. You kind of have to get a conventional wide field fluorescein. But this is a patient that ended up needing PRP. So in summary, OCT can demonstrate a wide variety of pathology, and new diseases are continuously being found using OCT. We did a little update on hydroxychloroquine and a deep dive into AMD and related diseases. Infrared photography is becoming more utilized in this area, in this era of geographic atrophy treatment, and OCTA is useful in many retinal vascular diseases, but FA remains necessary in some cases. All right, I have some questions here. Which of the following OCT findings is the earliest sign of hydroxychloroquine toxicity? We discussed earlier, it's B, disruption of the parafoveal interdigitation zone, which can come a little bit earlier than actually disruption of the ellipsoid zone. And then question 2, which of the following imaging modalities is the most useful in the evaluation of PDR? I'm a little biased here, but fluorescein angiography can definitely show you all the NV. So, thank you everyone for listening. Any questions? Okay, thank you.
Okay, and our last speaker of the night is our second newest member to our team, our Retina fellow, Dr. Alex Miller.
I'll use this. All right, good evening, everyone. This is the final talk of the evening. So I'm going to be presenting on some cases that I saw in residency. I did my residency at the University of Missouri out in Columbia. So first slide here. I don't have any disclosures. What we'll be going over here today are some patient presentations that I saw out in Columbia in kind of a grand round style. So this is one patient that we saw out in Retina Clinic out there. It's a 24-year-old male. They presented as an internal referral for macular edema. They had this strange past medical history of COVID-19 encephalopathy, and they also had ataxia, and they also had a complaint of diplopia. Interestingly enough, when we did some more digging, their half-brother had some sort of macular degeneration at 15, which is kind of odd, and their maternal grandfather also had some nyctalopia, or issues seen at night. So the physical exam for them, their vision, as you can see, isn't too good. The right eye, they're 20/70 plus 2. Their left eye is 21/50, but he can pinhole a little bit better to 20/30 and 20/80. Pressures are normal at 13 and 13. He didn't have any APD, and his alignment was ortho. So moving on to the anterior segment exam, you can see here it's generally normal, except when we kind of look at the lens status, we start to note that he had an earlier cataract at 1+ NS. And interestingly enough, in the anterior vitreous, he had 1+ cell. So we went ahead, we got our OCT of the macula. And as you can see here, thanks to Dr. Shieh's just previous presentation, if we pay attention to the ellipsoid zone in both of these pictures, you can see in the right eye that there's some disorganization of the photoreceptor layer. And then when you draw your attention to the left eye, you also see that same disorganization, and you also see some cystoid macular edema, which can explain why the vision's a little bit worse in that left eye. We ended up actually getting visual fields here as well. We got 24/2s, and you can kind of see a ring scotoma. So what you can think of visual fields when you see this is this just the ring artifact where the patient's just sitting too far away from their visual field and they kind of get that ring artifact, or is it something else at play here? But if you look at the left eye, you can see that there's actually a little bit more visual field depression superiorly, kind of correlating where the patient has their CME. The fundus exam here, you can see that they have this, the right and left eyes, you can see they kind of appear very similarly. If you look at the right eye, for example, you can see the media is relatively clear. The disc has this waxy appearance to it, and the vasculature looks attenuated with the superior and inferior arcades. And then he has this bone spicule type of pigmentary retinopathy in each eye, kind of going 360 degrees, but more pronounced nasally. So this leads us to kind of forming our differential diagnosis. You can actually have a wide differential diagnosis for these types of signs, ranging from trauma. You can see this in siderosis if someone has an iron IOFB, blunt trauma. Sometimes you can see this in certain types of drug toxicity, post-infectious states such as syphilis, toxo, CMV. Those are always some things that we can consider. Then the post-inflammatory states such as retinal vasculitis, and then autoimmunities such as cancer, carcinoma-related retinopathy or autoimmune retinopathy are things we can consider as well. But the overarching diagnosis is retinitis pigmentosa in this patient, given his bizarre early findings. He's 24 years old, and there seems to be a genetic component. So I'm going to be talking a little bit about retinitis pigmentosa. And so when I read about this in the books, you think that's kind of a funny name disease, retinitis pigmentosa, right? So we're going to look at the nomenclature a little bit. So where does the term retina come from? It actually comes from the Latin term, which is actually translated to meaning a net-like tunic. And when I looked into this a little bit more, a 14th century anatomist kind of thought that when he dissected the eyeball open, that the retina looked like a net almost because of the blood vessels within that thin translucent membrane. So throughout history, the first person to actually coin the term retinitis pigmentosa was a Dutch ophthalmologist, F.C. Donders, and that was in 1857. Funny enough, his colleague actually described all the findings of retinitis pigmentosa 4 years before that, but he just never coined the term, so he didn't get to name it. But now in modern times, we kind of know that this is more so of a misnomer because retinitis implies that there's inflammation, and we know that the disease nowadays is more so genetic rather than inflammatory. So right now, our books call it a rod cone dystrophy. A little bit about retinitis pigmentosa. It's a pretty common inherited retinal disease. Its incidence rate is about 1 in 3 to 5,000, but it's closer to 1 in 5,000 in the United States. It's typically bilateral, and it has a wide variety of inheritance patterns from autosomal dominant, X-linked recessive. There's also autosomal recessive patterns as well. And the onset also varies, so sometimes you can see this in infancy, middle, or late age. But the typical presentation is nyctalopia, or difficulty seeing at night, and that's a picture in the bottom right that kind of presents what night blindness would look like. And then visual field loss, and our patient has both of those. Here's kind of like a laundry list of genes that are involved in retinitis pigmentosa. I think the most common is RP63, and that's the autosomal dominant kind. So why does the retina kind of get the way that it does with this disease? And it's the pathophysiology behind retinitis pigmentosa. It typically stems from a disorganization of the rods and cones, specifically the rods. They're kind of shortened and disorganized. And then this causes stress upon that photoreceptor layer. And when the rods start to die from apoptosis, it then starts to cause the cones to suffer as well later in the later stages of the disease. So retinitis pigmentosa kind of has that classic clinical triad with the bone spicules, attenuated vessels, and waxy dyspallor. And I just wanted to put a slide together that kind of describes why each of these happen. So the bone spicules occur because the outer retina, specifically the photoreceptors, since they die, the retina doesn't need a strong blood supply anymore because the photoreceptors are one of the most metabolically active cells in our bodies. That then causes the inner retinal vessels to directly touch the RPE cells, and then the RPE cells then migrate along these vessels and form a spicular pattern. Now, the attenuated vessels kind of ties back to how the photoreceptors have died. There's less vascular demand on the choriocapillaris, which then results in a thinning of those vessels. And then when those vessels start to thin out, those vessels lose the tight junctions, which then the RPE cells also migrate to the vessels to try and plug those tight junctions. And then the waxy dyspallor occurs because there's a neuroprotective glial membrane that is produced by astrocytes and Mueller cells to protect the nerve tissue, hence you get that appearance. So let's just circle back to our patient here. So I want to focus more so on their left eye that had the cystoid macular edema. So he's 2150, has the macular edema. What can we do to make this better? So I went ahead, started looking at some literature, and this is a systemic meta-analysis, and those tend to have good data, especially for patients that have such a rare disease. This was released in 2022, and their purpose was to look at all the studies and provide an updated systematic review on all the treatments noted in current literature, because the most recent meta-analysis before 2022 was in 2015 on retinitis pigmentosa associated CME. So a quick touch on the inclusion and exclusion criteria. For their study, they needed patients that had retinitis pigmentosa and also had cystoid macular edema. And I just wanted to talk on the exclusion criteria, being that studies that only had a few number of patients, which is less than 5, and were published in languages other than English. So the treatments that were analyzed in the study were carbonic anhydrase inhibitors, that's your Diamox, methazolamide, acetazolamide, which is the Diamox, and then steroids. And then some studies compared the two treatments to one another. A couple other studies looked at CAIs compared to NSAIDs like your ketorolac. And then other studies did anti-VEGF, laser, surgery, lutein, and oral minocycline. So this meta-analysis had a lot of data in it, but we're just going to focus on the main outcomes here. So that being, one of the primary outcomes that were tracked was the change in central macular thickness, which is something that we really care about in patients that have cystoid macular edema. So the mainstay treatment that we all learn about in our studies is that how do you treat retinitis pigmentosa associated CME, and that answer is oral CAIs. So if you look here, the mean change in all the studies that tracked the central macular thickness and gave these patients CAIs, they noted a change of 62.65 microns. And then the next intervention I wanted to talk about were steroids, because I thought that that was pretty interesting. Usually we use steroids for patients that have pseudophakic CME. And so looking at this, the patients that had topical steroids had a change in central macular thickness of 58.56 microns. However, patients that ended up getting subtenon steroids had a dramatic change of 320.62 microns. And then I also wanted to touch on that Ozurdex had a mean change of, which is the intravitreal dexamethasone implant, had a mean change of about 182 to 216 microns. But those studies that had more dramatic changes are also more invasive. The study also looked at how many patients had rebound CME, because this is pretty difficult to treat in patients with retinitis pigmentosa. And the literature that they saw was about half the patients that were on oral carbonic anhydrase inhibitors had some sort of rebound, and they also had patients do topical CAIs, and they saw that it ranged between about a quarter to half of patients could rebound. So then some good points from the discussion of this article was that they said that the dexamethasone implant worked pretty well at reducing central macular thickness and improving visual acuities. However, it is more invasive as opposed to just topical eye drops or oral medication. They also touched on the laser, and what they did a grid photocoagulation, and it worked in the sense that it reduced the leakage that was causing CME. However, it would continue to constrict a patient's already constricted visual field. So there's a little bit of harm in doing it, but it did work for them. So I just wanted to circle back to our patient that we had. So we ended up seeing them near the end of October. We started them on Diamox or acetazolamide, 250 milligrams BID, and we just kind of kept them on that dose. And you don't really see a change until July, so it almost took 6 or 8 months. And what I have here are OCTs from his visits, and they compare the various times that he came in. And the top left ones compare the dates of his October visits to one another, and there's not too much change in the CME, but the most dramatic change is his visit when he came in July as compared to his March visit. It's almost, you get complete resolution of the CME. So that was one of our cases that was pretty interesting. And then I got another case here too. So we'll just go over this one. This one was a 15-year-old male with the complaint of consistent, spontaneous, blurry vision that started 2 days ago upon awakening. They had cold or flu symptoms for the last 2 to 3 weeks, and they went to urgent care, and they were this was during COVID times too, so they were COVID negative. Their social history, they moved to Joplin, and they were from Micronesia, so they don't really have much family medical history that they're aware of. Moving on here, our physical exam, the patient, they were 2,400 and count fingers in the right and left eyes, and their pressures were 18 and 13, and they weren't able to really complete any color plate or red cap desaturation testing that we were giving them. It was noted that they had like this ulcerated leg lesion below the knee. So we look at the patient here, and their anterior segment exam is pretty normal. So except they have a little bit of a dry cornea, some PEE inferiorly in the right, and an abrasion at 3 o'clock in the left. And that's an image of their external photograph, which looks pretty normal. But then when we get to the fundus exam here, we can see that these are their right and left eyes. You got these large boat-shaped hemorrhages, and you got, especially within the macula, you also have some subhyaloid, some sub-ILM hemorrhages as well. And then in the periphery, interestingly enough, in each eye, you have these hemorrhages with these white dots in the center of each of them. So we got OCT testing. The OCTs are very interesting because you can actually see that subhyaloid hemorrhage in each eye, which is causing a blocking effect or shadowing, as David was just mentioning to us, and you can't see the other retinal layers. We also got an OCT of the nerve, and it's not that great of an exam because our patient can't fixate too well. So differential diagnosis for this patient, you got to think of your myelodysplastic disorders such as leukemia, myeloma, anemia is also one that you can be concerned for, and patients that have those subhyaloid hemorrhages, anything that increases Valsalva could be something that would be a concern. Trauma, you can have ruptured microaneurysm, but at the end of the day, what this is Valsalva retinopathy in each eye, and he also had these Roth spots in each eye. So what we did, we ended up sending him to the ER that same day, and it came back that his CBC, he had a hemoglobin of 3.8, which is really low. So if you have a hemoglobin less than 7, you immediately get a blood transfusion. So his is almost half that. So he actually ended up getting admitted to the pediatric intensive care unit for mass transfusion protocol. And while he's there, he's getting all of these tests done because we just don't know why he has these low blood counts. So we got tick-borne pathology, RPP, blood cultures, hepatitis panels, HIV, histo, tularemia, almost everything under the sun, and those were all negative. The only thing that came back positive was the parvovirus labs, which were indicative of a previous infection but not active. He ended up getting bone marrow biopsy, which just showed that it was hypocellular for the age, and he was discharged after 9 days with the overall diagnosis of pancytopenia. So I just want to talk a little bit more about Valsalva retinopathy. What can you do for it? You pretty much have 3 tools that you could use. One is just observing, which is medical management. So what you want to do, you want to tell the patient, hey, if you're coughing or vomiting, try to use something that can avoid that, such as cough medicine. Sometimes if they increase their Valsalva because of their stools, then they can use stool softeners, and they have to avoid strenuous exercise as well. But the problem with this is that it can take a very long time, and it really affects patients' visions. Sometimes it can be upwards of 6 months, but that seems to be the mainstay of treatment that we typically do these days. The other treatment that we could do is a YAG hyaloidotomy, or you could go and more invasive and do a vitrectomy. So I thought the YAG hyaloidotomy was pretty interesting. So I just found this study here that actually had reviewed that a little bit more, titled here YAG laser hyaloidotomy and the management of premacular subhyaloid hemorrhage. So their inclusion criteria was that the patient had to have a subhyaloid hemorrhage of at least 3 disc diameters with no significant vitreous opacities. They had 22 total eyes with an age range of 18 to 76, and the pretreatment hemorrhage was about 6.27 disc diameters with a pretreatment visual acuity ranging from hand motion to 2200. So how did they do this? I was interested in that. So what these parameters are here are how many shots they had to do with the YAG laser, and they had, with these patients, they had a mean total number of shots of 2.5 with a range of 1 to 8 and a mean energy of 6.54 millijoules. So comparing this to YAGing posterior capsular opacification, it's significantly less number of shots, but just a higher amount of energy per shot. Visual outcomes that they had were pretty impressive because at 1 week they had a median visual acuity of 20/60, but the range was hand motion to 20/20. But if you can see at 3 and 6 months, the median visual acuity was 20/20 with a range of 20/80 to 20/20. And these are a couple shots of what an eye looked like before, which is photo A, before they had a YAG hyaloidotomy, and that is you can see the boat-shaped hemorrhage. And shot B, you can see that's just after they had the YAG treatment. You can see the hemorrhage is leaking out of the subhyaloid space into the vitreous. And then shot C here, picture C is 6 weeks after, and you can see complete resolution of the hemorrhage. A couple of the parameters in this study that dictated that they could go for laser treatment were that they had to have greater than 3 disc diameters. The hemorrhage had to be present for at least 3 weeks because you want to give it time to liquefy. And then if the patient is monocular or has a poor seeing fellow eye, then they would also be a good candidate for YAG hyaloidotomy. Some complications that were noted from this were that you can induce a macular hole. Sometimes you can put the patient at higher risk for retinal detachment if they don't have a PVD. And then epiretinal membrane formation. So that was pretty interesting. But if we circle back to our patient, this guy's 15 years old. He kind of is hard to do an exam on, so he's not the best candidate for the YAG. So we just did serial exams on him for a little bit. You can see that this was just a couple of weeks after he presented. Vision's a little bit better, 2150 and 2200, and the boat-shaped teams are starting to decrease in size. We followed up with him again in about a month and a half later. Visual acuity still relatively poor. This is his CBC, and his hemoglobin's improved with the mass transfusion, with the transfusions he's been getting biweekly. So we just observed him. But OCTs that we got that compare his visit from November to when he presented with us, you can see that he's starting to have resolution of his subhyaloid hemorrhage. And these images of the fundus here, actually, you can appreciate that the hemorrhage is decreased in size as well, as you can start to see some features of the fovea. So then this actually leads me to a case that we just did recently at Retina Associates. We had this 35-year-old male who presented August 25th, and he lost vision after vomiting. He presented with the classic boat-shaped heme on the left side here. You can see it, and he was a count fingers vision. We waited a month from August 25th to September 29th, and the hemorrhage just hasn't resolved. It's right over his fovea. He's very irritated with it, just wants to get good visual acuity in that eye as soon as he can. So we offered YAG laser to him, and just a week later, on October 3rd, you can see that he has 20/30 vision there after we performed that YAG procedure in office, and it only took 7 shots. So I thought that was just an impressive result for that patient, just something to keep in mind. Here are my references, and do we have any questions?
So Diamox is not very well tolerated, especially in young people.
Yeah.
And is that considered the only choice? And also, what's the usual expected course of CME if let's say, was not treated?
Mm-hmm. Yeah, that's right. Diamox is not well tolerated. You can have typically you get tingling in the fingers or toes, or you can get that weird metallic taste with pop or soda. But our patient tolerated it pretty well. We just kept them on a low dose of 250 milligrams BID, and you could go as high as 2 grams a day if you really wanted to. But if they have a reaction to the Diamox, then methazolamide would be an alternative that you could use. And if the CME just can't be treated at all, then that patient's visual acuity centrally will just be decreased.
So assuming that he took the medicine, you see a very sharp improvement after a long period of time on the medication. Is that normal course of the disease, or are we saying that's actually Diamox all of a sudden working?
I see. Yeah, I see what you're saying. So no, that's the Diamox working. So the disease itself can fluctuate, but the Diamox, if we didn't do any Diamox at all, then he'd probably continue to have the CME, and it wouldn't just go away on its own. Mm-hmm.
All right. Thank you, Dr. Miller. All right. Well, thanks again, everyone, for coming. We're here until 9 o'clock, so feel free to stay around for a little while. Just one note, if you can take your badges and just leave them on the tables, we'll collect them afterwards. And thank you again for coming. Mm-hmm.